Okay, let's go ahead and get started. Welcome to today's webinar. This is part of our celebration and acknowledgement of the International Myotonic Awareness Day, which happened just yesterday on the 15th of September. As part of that, we wanted to invite Dr. Benjamin Gallet, who has previously received funding from MDC for his project empowering caregivers to better manage myotonic patients' neurobehavioral symptoms. Dr. Benjamin Gallet obtained his doctorate in clinical psychology from the University of Paris in 2010. A clinical psychologist in France, he then completed a postdoctoral internship with the Interdisciplinary Research Group on Neuromuscular Diseases in Saguenay. This allowed him to deepen his knowledge of myotonic dystrophy type 1. The prevalence, as you all know, the prevalence of myotonic dystrophy is higher in this region in Quebec compared to other parts of the world and in the country. Today, Dr. Gallet's expertise in neuromuscular disease is recognized internationally. As a specialist in health psychology and neuropsychology, we invited him here today to talk about myotonic dystrophy and cognitive neurobehavioral symptoms, and for the first time, demonstrate some products of the funding that we had put forward towards this research initiative. Over to you.
Thank you very much, Amira, for this invitation. So if you can hear me well, I will start with my presentation prior to show the videos, of course. So it's kind of an old story that I propose to you today to go through myotonic dystrophy and this cognitive and neurobehavioral symptoms. So we'll go along. Sorry for the delay at the beginning, a lot of informative issues, but we're going to try to go through all these aspects very fast, generalities on DM1 and cognitive and behavioral symptoms. And we will go through all of these aspects: cognitions, emotions, apathy, fatigue, sleepiness, the impact on caregivers, and then our study. And if we got time, a little bit on the management, the possible, possibilities regarding this. So let's start with generalities very briefly, because if you're here, I guess it's because you are involved in the disease. So DM1 goes with several phenotypes from congenital to latent set ones. And of course, the earlier the disease starts and the more it is supposed you have some symptoms. So it goes like what we call a continuum of symptoms, and the latent set, the symptoms are slighter. But when we talk about disease onset, regarding age of onset, what are we talking about? And basically, most of the time we talk about muscular and maybe respiratory problems. But as you may know, there is many organs involved in DM1. And today we're going to look a little bit deeper in the brain aspect of the disease. So back in time when I was not performing, but doing my PhD thesis, I asked 41 people with adult phenotype of DM1 what was the most impeding symptom problem regarding DM1, what was the most impeding on their daily life. And as you can see, fatigue was the most important, the most prevalent, and then pain and functional limitations, which is pretty expected in a neuromuscular disorder. Myotonia also was pretty prevalent. But the thing is that cognitive problems, motivation, or even anxiety were less frequent. So other all what we call neuropsychological problems were prevalent, but it's more about fatigue and sleepiness, So my point here is that most of the time, patients themselves are very aware about their fatigue and their sleepiness, but less regarding other aspects of the disease, such as cognition and apathy. So it is important, I guess, to point out that what we call neurobehavioral symptoms include executive, cognitive, emotional, social, behavioral problems that are associated with the central nervous system impairment or alteration related to the disease. And it includes, as you can see, numerous aspects of the disease that are pretty frequent in DM1 and also in DM2. So if we go further describing those aspects, we have the cognitive portraits. Again, I will be brief, but there is a general cautions that we should have. Not all the signs in everybody, which means that you maybe are affected with the disease, and you may not recognize these signs for you or on a person that you know, a sport or whatever. Okay, so phenotypes also, there is a very important aspect. As you know, it's more like a spectrum, and as I said, a continuum. So this is not strict with age and these symptoms. You know, the categories are overlapping sometimes. So what the scientific literature showed us is that reading, writing, delay, difficulties, you know, in congenital patients, maybe sometimes they can't read or write at all. It has been observed the language delay, communication and behaviors problems. And we talk about autism spectrum conditions. And the spectrum is large, which means that sometimes it is not typical autism as we can think about it, but some traits, some characteristics are found in congenital patients. The childhood phenotype now. So if we look at that, attention problems have been showed in the scientific literature, difficulty to focus, to switch, to inhibit our attention when it's necessary to do, and switch to another task or another aspect. So this is something that is pretty frequent. Working memory, which will lead to difficulties in math, for example, visuospatial difficulties that will have as a consequence geometry difficulties during school, and the difficulty to select the right information, to organize the visual information. There is also a description of ADHD, so attention deficit. Of course, we showed that in cognitive tests, attention is pretty difficult, and it's also something that you will see in a daily task, in daily life organization. And hyperactivity, sometimes it's observed in childhood, sometimes not, because sometimes it's only the attention deficit that will be observable, you know, because the patients are slowed by the disease, fatigued, so the hyperactivity is not present, but sometimes, yes. Social relations also are problematic in certain circumstances, and the AAC, the autism spectrum condition, is less frequent and less obvious than in congenital patients, but sometimes, because, as I said, of the overlapping between the phenotypes, it could also be seen. In adult, so adult, you know, even childhood, we juvenile aspect, it's less described in the literature, and the late onset as well. So if I go to classic adult phenotype, we mainly observed processing speed difficulties, mental flexibility, organization and planification, some difficulties to recognize emotion or visual emotion in others, some interpersonal abilities that sometimes are difficult or missing, and decision tasking is also very difficult. So as you can see, the spectrum, but also the continuum, we go from autism, which means, you know, very, you know, great difficulty to be in a relationship with others, to smooth, slighter difficulties in interpersonal abilities. Regarding the evolution of cognitive aspects, again, less works, less studies than the description, but still some good studies we can talk about, and they have shown a decline in adult phenotypes regarding attention, processing speed, visual-spatial, visual construction, memory, and executive functions, depending on the studies. Again, sometimes it is one study says, yes, there is a decline, another one don't find it. So we are always trying to do it again and repeat, the studies to better understand. And what is the impact of this evolution, the decline of scores, in neuropsychological tests? What does it mean in real life? I mean, what we observed in a 9-year longitudinal study that we made here in Saguenay, Lac Saint-Jean, with the GRIM team, which is a lab that we are focused on neuromuscular disorders. We observed that, yes, there is a change in scores, in mean scores in our participants, but regarding the category that, tell us if there is a normal range, a mild impairment, or a moderate impairment. So what we observed is that only 2 cognitive functions were passing from mild impairment to moderate impairment, and they all are about speed. Like speed was normal at the beginning of the study and then was mildly impaired, and visual attention was actually also normal and declined rapidly and become a moderate impairment in our patients. So this is the kind of things that we have to be aware of. And globally, the speed is declining, which is a sign, that there is something going on in the brain. It's a neurodegenerative process. But let's be careful. It is a slow progression, like studies, longitudinal studies, they go from 5 to 11 years. And only with this long frame of time, we can observe decline. So, it's not coming from one day to another, but maybe you experienced a change in your ability to function in daily life, and that could be associated with this kind of decline. Also, I wanted to point out, because with our team, we are maybe not the only one, but one of the international teams to describe the latent set phenotype, which is a phenotype that is observed after 40, sorry, I've seen some message in the chat. I will focus on that later. I should not be distracted, So anyway, the latent set has always been known to be a paucisymptomatic, which means that maybe only a cataract or, things like that. But what we observed in the 9-year study is there is a decline also in latent set participants, which is very important, I guess, not to stress out that, there could be something to be aware of, but most importantly, because these persons, these individuals, most of the time, they come to the clinic and they are wondering why they feel that they can't concentrate, as well as in the past, So these patients, these participants are specifically very active usually, and then they feel something that is slowly but surely changing. And I think it is important to support them to say, yes, maybe it's because of the disease. It's not something else, but it's important for their own history, I guess. For the other phenotypes, we have much less information, but one very interesting study from the Swedish team showed that in the congenital group, there is a tendency to decline when we talk about intellectual disability. And also there is a widening in the gap in level of functioning versus normative data, which means that the gap that were observed during childhood, it tends to widen with time, So, but it's only one study, so we have to be careful. And in the childhood phenotype, again, one longitudinal study also, and they showed no cognitive decline from, the first assessment between the first one and the second one, long time after, around 10 years after. So this is very encouraging. However, what we have done in our lab, we questioned ourselves about what about children with childhood phenotype when they become adults? So we made a preliminary study with only 11 participants, but we observed frequent difficulties in what we call instrumental activities of daily living, which means all the tasks that we have to do day to day. But instrumental, it's the more complex task, you know. So, for example, money management, social adjustment, things like that were pretty difficult for the person we have assessed. And as a whole, only one participant on 11 required no help at all in all the categories that we assessed. There was a strength, memory orientation was a strength. So, and this is very important to stress out. So we conducted another study with 33 participants this time, still in the Quebec region, in Saguenay-Lac-Saint-Jean, in Canada. And we again found difficulties in these instrumental activities of daily living. And we went through, more refined assessments. And again, we found that the budget management was something that was very difficult for these adults, you know. So again, it's adults with the childhood phenotypes, but when they grow up and they are supposed to be maybe autonomous, they encounter, they experience financial budget management difficulties. They also have difficulties to formulate a goal, and difficulties regarding health and security, which means when we ask, classic question about what to do in this, if this happens, what to do if this happens, their answer are not as good as expected in the test. So maybe they don't really know what to do regarding health and security, okay? And autonomy, again, memory orientation was pretty good, and clothes and shoes were pretty good. So what is important here is that, except of course clothes and shoes, but again, your brain is very important to sometimes we don't think about it, but even just to get dressed, your brain has to tell you unconsciously what to do and in which order to do it, okay? But what we observed is that the more the activity is complex, the more these participants were dependent, okay? Because it requires executive functions, what we say, so organization, planification, etc. And so in most cases, participants required assistance to perform an activity. And again, when we do this kind of studies in our group, it's because we think about the impact of the disease in people, in the individuals. And for us, there has been a lot of study during childhood for the childhood phenotype, but much less when they get adults. So we don't know if they can live independently, So I think these information are very important for the person themselves, but also for caregivers, for parents who maybe grow older, and are really questioning themselves about, on what's going on with my children, okay? So everything we do here is also to make, people, government, and more aware about this situation. So if we go on the employment impact, I know that many people affected with by DM1, they are all employed, but still there is a pattern that I have met a long time before when I was a clinical psychologist in Paris, before to come as a full researcher in Quebec. And the patterns I've met is that, okay, let's take juvenile and childhood phenotypes. They discover the disease, they try, they start to get along with it, and we have a good follow-up in the neuromuscular centers. But if we don't think about it, most of the time, the first reflex, because of the level of difficulty encountered by these persons at school, we're going to think about, okay, you should, orientate your scholar pathway toward manual jobs, and sometimes adapted, protected jobs, which is totally understandable because, again, of the learning difficulties. But just to be, oh, sorry, too many gestures with my hands, just to be aware that one day, maybe the functional handicap may progress and may lead to difficulties to perform this kind of works, so manual jobs, it's when they get adults, sometimes it's more difficult with hands, with strength, and, and functional limitations. So just we have to think about it. And on another way, for adult and late onset phenotypes, most of the time they discover the disease and everything is more focused on the muscular limitations. So sometimes they even, a lot of people said, I can't stand up for all day long and everything. So we go to a reorientation, and I've seen a lot of women with DM1 who try to change their job and go to secretary, desk jobs, And again, this is totally understandable and very important because of the evolution of the muscular disease. But let's be aware that what I call the invisible handicap may progress also, and this should be considered because desk job, as we call it, they require a lot of attention, what called double attention, which means that you have to do two tasks at the same time, and planification and everything. So all of these aspects may be one day or another where it may be difficult, to perform. So again, let's be aware about that. DM2 specificities, globally, the scientific literature showed us that DM2 had less frequent, less prevalent, and and a lesser level of impairment than DM1. But it is very important to do more research, and a very, very recent study of Peric and others lab showed us that, regarding 76 participants, one patient on 4 presented a significant cognitive impairment interfering with everyday functioning, which is really what we have to focus on. About 35% presented cognitive impairment, like over the fact that people think it is a limitation, like strict cognitive impairment that we can observe thanks to assessment. And most affective domains were visuospatial, executive, and naming, which is pretty close to what we observe in the classic adult DM1 phenotype. Emotional disturbances. I will try to go a little bit faster now, but what does depression look like in DM? So you've got depression, you got major depression, and DM brain-related depression. This is something that I've been working on for a long time now. So the classic major depression most often occurs as an episodic nature. So occur in relation to specific situations related to the disease. So it's like a reactional depression, which is totally logic when you have such a disease, So for example, while a diagnosis of DM is done in patient themselves or a relative, because we know it could be a family disease. So in this period of time, it is not uncommon to feel depressed and to actually experience a major depression. Also, the evolution of the disease, it's not, it's a chronic disease, but it's an evolutive disease, which means that we may diagnose a new problem in your, in your health story, like cardiac, respiratory. You can walk, and after a few years, start to have limitation walking. So all of this, of course, could impact your emotional reaction, and you may experience you or your sorry, or someone that may experience major depression. And of course, I always say we, I'm sorry for that, but people living with this kind of disease, they are not only the disease. You know that, sorry for my English, but you understand what I mean. There are still many other aspects of life that could also occur, and other issues, at work, at school, difficulties in a relationship, in finding a partner, or losing a partner, everything like that, that are not specifically related to the disease, but also could have a big impact on your emotional reaction. Also, physical change in you or your family, they also could have an impact on your emotions. So this is one aspect. And the other one is more DM-related depression, which means that what I call the invisible handicap, that could mimic major depression, the symptoms of major depression. It's more about the chronic state. And we thought, and we start to have indices, but it could be brain-related, directly caused by the DM. Okay, so everything that we're going to pass through this webinar, this presentation, actually, sometimes it mimics major depression, and but it is not real or actual major depression. It's more about a lack of emotion that could be negative or positive, apathy, lack of motivation, which is also a sign of depression, but it also occurs more frequently in DM1, as we will see. The fatigue is a sign of depression, but ask anybody with DM1, they are fatigued, even though they are not depressed, So daytime sleepiness will also lead to problematics regarding sleepiness that could be misunderstood with depression, and some thinking problems, cognitive problems that we just described. So all of these features are for me what we call neuro or psychobehavioral syndrome related to DM. So let's talk about prevalence now. In DM1, of course, depending on the studies, but I didn't want to do an exhaustive presentation, but about 18% of adults could be feeling sad or depressed at the time. And the severity is generally not very high. Again, it has to be taken with caution. It's always bad, to be depressed. What we mean here, not very high, is regarding the categories, the tools that we use to assess, depression. It's not, so high. In DM2, actually, more percentage have been found in this study. 28% reporting having depression with major or moderate impact. But what I've said, it's that there is no consensus on tool used to assess both depression and anxiety, heterogeneity between the studies. So it's very difficult to say, oh, this is this prevalence or that prevalence. It's pretty difficult even in research because of the way you assess it. So anxiety, as usual, when people are confronted with a disease, irritability, poor self-esteem could occur or not. Again, everybody is very different and will experience the disease very differently. But for me, it is more typical, anxiety there is no such DM-related anxiety, like specific brain origins, It's more about everything that people could, go through because of this kind of disease, fearfulness that could lead to avoidant behavior, which is very important. You can fall in fall, sorry for the term, but actually, you can be in a vicious circle because the fear of falling, I'm not trustful with the way I walk. The fear of falling, makes me avoid stairs, for example, and it will impact, will have diminished walking and activities, and then it could lead to inactivity, So please, don't, if you feel that you are in this vicious circle, it's very important to talk to your the nurse or whoever you can trust in, and take each aspect of this circle separately and try to avoid to become avoidant, if I may say. So we observe also excessive physical preoccupation, which could lead to hypochondria. I mean, again, it is totally normal, understandable to have preoccupation about the disease and the physical aspect of the disease, and my body is changing. It's totally normal, but you can talk about it with professionals to not become anxiously preoccupied, because anxiously preoccupied means that you are preoccupied, but you can't do anything about that. And this is anxiety, Just understand that it's normal to have preoccupations, but it should not inhibit you, okay? And actually, social inhibition is also something frequently observed in DM. And the fear of the future, which also could be very inhibiting. But most of the time, patient told me, I live day by day. I don't have control about the future. So again, it's difficult to be focusing on what we don't have the control. Prevalence, about 16%, would have current clinical anxiety at the moment of the study regarding the individuals that they have assessed. In DM2, we don't know yet the specific prevalence. More studies are needed. So key definitions regarding emotional disturbances. Again, brief period of sadness or uneasiness in certain situations are normal and are even expected when we have such a disease. And also in life without the disease, like sadness after the loss of a loved one, separations. It's normal to be nervous before a public speech, as myself. But depression and anxiety are medical conditions that require treatment. When it becomes distressing, persistent, and it disrupts day-to-day functioning. Again, you can have a very episodic period of depression that will disrupt day-to-day functioning, and you should, get helped. But also sometimes it goes away by itself when it's for a very specific situation. But when it becomes persistent, you have to be aware and require help. So some warning signs. I will let the slides, so maybe we can go faster on that. But of course, as I said, for depression, sometimes it's very difficult to consider if it's just DM1, like less appetite, fatigue, sleepiness problems. These are so common that we can't say it's because of depression. And even loss of activity because of apathy and because of the reality of the disease, sometimes it's also expected. But if you feel guilty, if you feel down and emotionless, that could be a very specific sign of depression. And I would say guilty even more than emotionless, okay? And of course, the feeling of uselessness, hopelessness, and of course, thoughts of death or suicide, those are very warning signs of depression. Okay, so anxiety also, it could be, as I said, normal to be, stressed about something, vigilant about something. But if you are worried and hyper vigilant of something that you don't have the control of, that could be a period of anxiety. And again, the same life outlooks and feelings that you should be aware of. So again, I want to stress out this aspect. What are the consequences of emotional distress? Look at this. Those are quotes that I took from a very interesting paper. When I work, I'm dead tired. I work as little as possible. This is a kind of avoidance, but for me, it's strictly related to the physical impairment. I'm so tired that I can't walk, so I try to walk as little as possible. This is kind of normal. Again, you can be helped about this with OTs, occupational therapists, and everything. But still, the avoidance for me is not so preoccupating. But here, not reading all the things, but because of the physical limitations, this lady quit shopping just to not be confronted socially with our limitation, by our limitation. So for me, it's in avoidance related to both physical and emotional issues. And this is a kind of vicious circle that we don't want you to get in, okay? So let's talk about apathy now, which is another symptom or syndrome of our neurobehavioral palette, features. So apathy is a lack of initiative, but also a lack of interest in activities, emotions, and even care, daily care, and care related to DM, which could be, again, very confronting. It disrupts health because by itself, the lack of interest in your own care could promote treatment non-compliance, And there is another impact that is very important. It's the source of distress among couples because apathy, most of the time, it's not complained by the patients, but by the partners. And it would affect about 40 to 55% depending on the phenotype, which is, again, not futile. I think it's very important to talk more about that, and some quotes, like my wife suggests, should we go on holiday? I say, okay, just tell me where, I don't care. So again, this is maybe not stressful if you read it, but for a spouse, for a partner, every time, you have to it's depend on you as a caregiver. So sometimes it's burdensome, And someone again with DM1 said, because you are at home most of the time, your world becomes smaller, which is very annoying for me. So this time, this is a person with DM1 that is aware, and complaining about apathy, which is more rare. And a woman partner said, what can be postponed was postponed. It completely irritated me, So we see here the frustration of the partner. There is also fatigue occurring in DM and DM1 and 2. So in DM1, for example, it occurs in up to 91% of the people that were assessed in in most of the studies, actually. And it's the second most experienced complaint. It was the first one in my study, but in a very big survey, it occurred actually both in US and Canada. It's the second most experienced one. So again, it's very, very common, and it had the greatest effect on the M1 patients' lives. So it's frequent, and it has the greatest impact, even more than muscular or myotonia, the main features of the disease. So very, very important. And sleepiness also, it's up to 88% of individuals with DM. Again, very important. Most of the time, some people consider it's overlapping, it's the same symptoms, some other not. And, so if you want just to understand a little bit. Fatigue is strictly physical, intellectual, and emotional lack of energy, when sleepiness is an urge to fall asleep in a situation that is not appropriate, like in class, social event. So most of the time people experience both of them and they can't really distinguish between them, but it is two things that occurs at the same time, but are different, okay? And it has, of course, a great impact on emotional distress, lower quality of life, more social and occupational engagements, because every time you have to do something with your friends or your family, but I mean, I go already too far, but you know that you may be fatigued. So you try, and you're fatigued or you fall asleep. And what I was saying, it's also another vicious circle, is that sometimes you anticipate to not do something social because you anticipate that you will be tired. So, which is true, and sometimes maybe not, but it's unpredictable. So again, it's very difficult emotionally. And actually, this quote said, it's like a roller coaster. Some days I'm, as in all the days, I feel good. And the next, I am not able to do anything. And then I can feel depressed because we feel guilty about it. And sometimes we're just anxious because we anticipate that it will happen. And it can freeze plans or spontaneity, which again could be burdensome for partners. So I will go further because I have also other things to say. But again, it has a great impact on caregivers. It's increased the burden. It changed the family responsibilities. Sometimes the children do more at home than one of the parents because of the disease, and it could lead to social isolation, marital dissatisfaction, hopelessness, and anxiety. So personally, I try to say to caregivers, first of all, to attend, the patient's medical appointments, not to, how can I say it, to take off responsibility of the patient. But we observe that sometimes, because of the lack of awareness, caregivers are better to bring up, the concern and describe the situations better than the patient themselves. But I don't want to say that we have to take off again the responsibility of the patients, but it could help, the follow-up of the care. And take good care of yourself, because we can't help if we don't someone if we don't help ourselves. We have to be strong, to help someone. So we need, caregivers need help and support and time, good time. So a lot of tips that you will find in the slides. I ran short with time, but anyway, pretty much of this is in the videos that I wanted to show you. And actually, we're here today to show you for the very first time, and I'm very excited and proud of this work. It's a project, again, financially supported, and not only financially, but also we had the help and the support of Muscular Dystrophy Canada all along the project that we have made at the Green and Cégep de Jonquière in Saguenay-Lac-Saint-Jean. So very briefly, because of my past of clinician and being a researcher, I wanted to mix both of this and to develop and transfer information and practical tips to empower caregivers regarding neurobehavioral symptoms of their affected ones. And the thing is that, very briefly, we mixed scientific methodology with something that is very individual directed, like affected and caregivers directed. So we interviewed 90 caregivers, all kind of caregivers, spouse, children, parents, roommates, friends, and we asked them what are the problematic situations you are facing, what kind of information you would need, that you don't have, and what are the strategies you are using, because we are pretty sure that people develop very important and very efficient strategies, but that don't know it is efficient, or they just don't say it to the community. So then we analyze this and we develop 4 videos.
Wonderful, wonderful. Okay,
So,
so I
yeah.
can go to the first question that we received, which is a question that you've addressed, but it would be great to summarize this response for others, which is how do neurobehavioral symptoms look different in those who have later onset phenotype versus adult onset phenotypes of myotonic type 1? So are there differences depending on when the myotonic dystrophy started to present itself is the question.
Yeah, sorry, I was uh, stopping the sharing, so I don't know if I will if I heard well. But so, how does it present depending on the precocity? So the phenotypes actually,
Right.
yes.
Yeah.
On the cognitive aspects,
Yes.
yes. So yes, as you say, I presented it a little bit, which means that the earlier the onset of the disease occurs, greater are the symptoms. So as we said, we can talk about mental retardation. I mean, again, it's very basic what I say. I go straight to the goal, and everybody will not experience that. But again, with a congenital phenotype, which occurs, in utero or during the first year or after the first year of birth, you may, I mean, the child may present with mental retardation. So you can see that it's big. It's not said that it will not develop, after that, but there will have some aspect of the cognition that will not be present, as I said, maybe writing, reading. And so then if we go further in the phenotypes, if the phenotypes occur later on during childhood, there's still difficulties, but it's more going to be about mathematics, geometry, but reading and writing will be okay, if I go straight to the goal. And when you develop it during adulthood, again, you still have cognitive impairments, but it's more subtle. It's more invisible, and most of the time people had, let's say, a normal scholarity. I say let's say because most of the time, again, my point is, if we say that the disease occurs after 20 years old, it's because you start to have muscular problems, and then we put a diagnosis. Most of the time, we as neuropsychologists, we understand that there have been problems before regarding cognition, but still, if I want to be very categoric, let's say that the cognitive impairment is more subtle with, short memory, but the short memory is preserved, but the planification of your memory may be difficult. So you will not be able to perform a memory task maybe as someone without the disease, but it's not as big as mental retardation. I don't know if I'm clear enough.
Well, that's great. Another question is, so actually right now there are clinical trials for myotonic dystrophy in Canada, much of which are really focused on the underlying root cause of the disease. But there's a question that actually came in ahead of today's webinar, which was more so saying, is there current promising therapies or treatments on the horizon to address the impact on the brain? Are those under study? So I know about a year or so ago, there was a clinical trial on daytime sleepiness. What about in terms of apathy? What about in terms of, depression? Are these the targets that treatments in the future will have? Could you impact the brain function for those with myotonic?
Yes, I mean, again, it's we have collaborated with some of the labs regarding this. But yeah, it's very encouraging. The way the drugs can, reach the CNS. It's sometimes very challenging. We are not. I can't say that tomorrow it's going to work, but yeah, totally. And actually, maybe I'm biased because of my neuropsychological point of view, but I would say that a lot of treatments that are ready to almost ready to go on are actually targeting the CNS, the neurobehavioral aspect that I just presented. So it's very encouraging. So yes, and waiting for these drugs, and I've seen another question in the chat, and I can just rebound on it. Actually, waiting for it, yes, Ritalin, for example, psychostimulant. Clinically, they have shown some very promising aspects. And actually, I have an idea to try to assess these effects, not only on attention, because it's supposed to work on attention, and but also on fatigue, sleepiness, apathy. What is the impact of Ritalin? Because again, clinically, patients sometimes we give it for attention deficit, but they feel better regarding other aspects. So I think it's very interesting to go with the accord, the acquaintance of the doctors. You can go in this aspect prior to have the great treatments that are working on with the labs. Yeah.
And I know the focus of today has been on myotonic dystrophy type 1. A few comments that have come in is around myotonic dystrophy type 2, which you and I spoke about ahead of today's webinar. But I think the sentiment is the same, in that there needs to be increased research on this topic, on both types of myotonic dystrophy. We'll just go with one final question here, which is in terms of are there, and I think you spoke about this, but just for as people watch this webinar, what are some things they can do to preserve cognitive function or really manage it? So not thinking therapeutic with a treatment, but what are some proactive strategies or tips you'd like to end off today's webinar with?
Yes, I mean, it's sometimes it's kind of complex because it goes along with apathy, and then there are many behaviors that actually could preserve cognition that are not. But to make it simple, yes, if you could keep on being very active cognitively, which means that play card games, even on the cell phone, it's okay. There are many games, but if you could uh, do games that have a growing difficulty, that would be very helpful. This is the kind of tools that we use for cognitive rehabilitation or preservation, actually. So yes, so instead of just watching TV passively, I would say, if you could get engaged in activities that are more cognitively active. Also, and this is a problem, as we may say, but still keep being active socially, and of course in the family, but also outside of the family. Many other studies I have reached or conducted showed me that it's very difficult sometimes for DM1 people to go outside of the close circle, and it's challenging to be in the society, to have social activities outside of the family. It's more challenging, and it's more preservable for the brain. And of course, all of the rest, like walk if you can, or if you can even go to walk a little bit, or aerobic training. Try to eat well, which is I know maybe difficult to say, to throw it like that, but it's very important for the brain. So, and sleep, and it's important for many aspects in the M1. If you could sleep regularly, with the same time schedule, and for all of that, if you can't do it by yourself, you can ask help for your team neuromuscular center, or even your your doctor or whatever. Not only the neurologist, but just say, help me to have to preserve a more accurate way of living, and they can help you with different kind of programs. And it's not so complex. I would say, I mean, it is complex, but you don't have to see a psychologist, for emotional disturbances. Yes, but you can talk to anyone and ask, okay, I need to make a calendar, and to focus on my behaviors, and try to do things like that. Because one of the main aspects in the end, yes, the disease progress, but we don't, even us, of course, there is a genetic link between this decline, and the way the brain progresses. But we don't know yet what is the part of the behaviors that DM1 people may have because of apathy and fatigue and everything, So which is the part of the fact that most of the time they don't stay active for a while. We don't know yet, and I'm sure it's a great part of the cognitive decline.
Wonderful. Thank you so much, Dr. Galley. A really clear, informative presentation today. So
Thank you.
helpful for us to, again, mark International Myotonic Awareness Day with more information. It's also a good reminder as an organization, as we advocate for access to disease-modifying therapies and treatments, really thinking more holistically about life and how to participate with families and friends and the function it has in terms of behavior and characteristics and personality. And so thank you. Thank you for a really important talk. Thank you all so much for joining and for your support of our Let's Talk NMD webinar series. We wish you all a good rest of your day. Thanks so much. Please reach out to research@muscle.ca if you have any questions on myotonic dystrophy. Thank you again, Dr. Kelly.
Thank you very much. Bye.